Eight, five, four, three, 1, 2.
Welcome, welcome everyone. Well, crossing 2,000 members on our Rising Star in Ophthalmology series brings us extreme joy. But more importantly, it brings us a lot of responsibility to bring you guys the best of the best. For the folks who didn't join us for the last few times, Rising Stars in Ophthalmology Season 1 is a 9 episode series, interactive series that will focus on bringing you the absolute new innovative technology from speakers, according to me, that are the finest clinicians, surgeons, and orators in the world of new ophthalmology as we see today. The program is being aired on risingeyestars.com and Facebook and YouTube channels of Rising Stars in Ophthalmology. We love questions from you guys. So we will love you guys to go into the website and put down any question that you want during the session is while the session is going on any of those platforms, and we'll have those questions answered. Since the series is a global event and the timings may not suit a lot of people around the world, all the episodes are available on risingeyestars.com for everyone to view, but only on our website. So don't miss out to go in and watch it if you have missed any of the previous episodes. Because remember, old is gold. As of today, we have an absolutely fabulous celebrity panelist, Starcast, and we also have a speaker who really needs no introduction and is exceptionally well accepted around the world as a rising star in ophthalmology. I would love to introduce right now my co-moderator, Jennifer Lowe, to please introduce our special talk for the day, and then the panelists and speakers.
Thank you so much, Ashman. It's an honor and pleasure, as always, to be able to co-moderate with you on this exciting new series. Before we get started and before I introduce our panelists and speaker, I did want to, first of all, thank all of our Season 1 sponsors. And you can see here on our sponsor list, I did want to take a moment again for everyone to acknowledge their support, without which we would have a hard time producing this series. So thank you again. And now I'd like to introduce our special speaker for tonight, Dr. Debbie Risvet. She comes from Minnesota, and where it's very cold right now, as we've discussed. And she's here to speak to us a little about a special talk right now. Thank you, Dr. Risvet.
Thank you guys so much for having me. And it's such an honor to be amongst people I admire so much. And I want to thank Alcon too for allowing me to talk about something that I'm passionate about, and that's the Sustain ILUX system, which is a meibomian gland disease thermal pulsation system. And so if you want to pull up the slides, we'll talk about ILUX. And so as we know, dry eye is a chronic progressive disease that really negatively impacts our patients. And so whether you're a glaucoma specialist or a cataract refractive surgeon, we all have dry eye patients that we definitely need to treat. And so as we're treating, we know that 30 million patients in the United States actually have dry eye, but only 16 million are diagnosed. And so what more can we do for them? And this is where I was really contemplating different technologies and how I could add value to my patients. And the iLux system was a very easy way to integrate that into my practice when you talk about efficiency, customizability, and really getting the end result that you desire, whether it's cleaning up the surface before cataract surgery or providing relief to patients that are really struggling. So with the iLux system, it takes about 8 to 12 minutes to treat all 4 eyelids. And it's nice because it's done under magnification. So you can really see the meibum being expressed as you're doing the treatment. So it's customizable in the effect of really getting to the glands that are problematic. What we know clinically and statistically is that we're seeing results after 1 week of treatment. Alcon also provides different platforms like Dry Eye Excellence Program for practitioners trying to navigate how to utilize this platform, as well as Sustain My Eyes for patients that really provide continuity of care after treatment. And so I want to thank Alcon so much for allowing me to be part of this, as well as you all, and have the best time tonight listening to a phenomenal speaker.
Thank you so much, Dr. Risvet. We really appreciate that great introduction to the iLux, and thank you for being part of our season and our series tonight. Okay, so next I would like to introduce first, before I get to our speaker, I'd like to introduce our celebrity panelists. And we have hailing from Chennai, India, Dr. Susan Jacob. We have from LA, Dr. Netta Shami. And we have from Indianapolis, which is actually my original hometown. So I have to give a shout out. We have the famous Dr. Frank Price. All right, so thank you all to our celebrity panelists again for your time and expertise on tonight's episode. We couldn't do it without you. All right, so next I would like to introduce our speaker, and I do have a PowerPoint that actually Dr. Beltz graciously helped me put together that I'd like to share with everyone today. So first of all, many of you already know the wonderful Dr. Jackie Beltz, but I wanted to give a proper introduction. She is a cornea, cataract, and refractive surgeon from Melbourne, Australia. So we actually realized that it's already tomorrow or Wednesday where she is. So she's already one day ahead of most of us, except for Dr. Argawal and Dr. Jacobs. And many of you may be listening tonight, but I always find it interesting. And I've never been to Land Down Under, but I hope to visit Dr. Beltz soon. She's also the chair of the Australian and New Zealand Cornea Society, and she's a director of training for Victoria, Australia. I love the photos she put together for us today, showcasing her personal life. Many of you may not know, but Dr. Beltz actually spent 2 years doing her cornea fellowship, part of which she spent in Italy, training under the famous Professor Busen. And I have to say, knowing Jackie on a personal note, she is one of the most traveled ophthalmologists that I know. She is so dedicated. Multiple times a year prior to COVID, of course, she would go to many US and other international meetings. And so I've always admired her dedication. She also helps train residents and is raising a beautiful daughter named Betsy, along with her husband and her dog. So without further ado, Dr. Beltz, we'd love to hear your presentation. Thank you again.
Thank you so much for that introduction, Jen, and thank you everybody for having me. It's really an honor to speak as part of this first season of Rising Stars. I'd like to thank also the sponsors and the organisers and all of the panelists for showing up, as well, of course, as the audience. I miss you all so much now that we can't travel, so it's really great to be here doing this presentation today. I'm going to speak about cataract surgery in patients with corneal disease. These are my financial disclosures. And there you can see an image of my hospital, the Royal Victorian Eye and Ear Hospital in Melbourne, as well as one of the laneways that my city is famous for. As mentioned, I'm presenting from Australia, where it's Wednesday lunchtime, and I'd like to acknowledge the people of the Kulin Nations, who are the traditional custodians of the land on which I stand today. I would also like to pay my respects to elders past, present, and emerging, and to any Aboriginal and/or Torres Strait Islander people watching today. I would also like to extend this acknowledgement and pay my respects to Indigenous peoples of other countries who may be watching. The key areas that I'll cover in this presentation are forward planning, visualization, endothelial protection, wound integrity, and complication management. And then we'll go on to discuss some specific cases with particular focus on IOL selection. As with all complex cases, it's important to start with forward planning. I really believe this is the one place where we can make the most difference. Making sure the patient is counselled, anaesthesia is adequate, and all instruments and hardware are prepared and in the room goes a long way. Also important is allowing enough time so as not to be in a rush and really paying attention. At the end of the case, you want to feel, and your patient deserves to know, that you tried your best. Also important in terms of planning is preoperative management of corneal conditions. Things like dry eye, mucous membrane pemphigoid, epithelial basement membrane dystrophy, and herpes virus must be optimised prior to biometry and prior to surgery. Consider any additional procedures such as pterygium excision, PTK, removal of band or Saltzman nodules, etc., that may be best done several months prior to the cataract surgery. And also consider either yourself or in collaboration with your corneal colleague whether this patient might be suitable for corneal transplant, either prior to, combined with, or after cataract surgery. This decision is really complex and depends on a number of factors, particularly the patient's visual prognosis and situation and their risk factors. My general preference in combined procedures when endothelial keratoplasty is necessary, and staged when it's an anterior lamella or a penetrating keratoplasty, but that does vary a lot. Visualization is often the most challenging feature of cataract surgery in patients with corneal conditions. Capsule staining is really important and readily accessible in many centres. I recommend that if you have it, using trypan blue for all eyes with corneal disease, as sometimes the view can be deceptively good at the start, but it can get worse, and depth perception can also be difficult to gauge. So the stain can really help a lot. I recommend injecting the dye under air. Trypan blue is a vital dye, so it stains dead cells. Patients with corneal disease may be more likely to have corneal uptake of the dye that can interfere with the surgeon's view, as shown in this video, where I knew the patient had endothelial disease, but still didn't inject enough air, and you can see that the cornea stained there. So I've got my first question for the panel here, and just to introduce it, this is a case that I did last week, a young patient with a history of congenital glaucoma who had a failing endothelial keratoplasty and a tube. Dr. Shami, I thought I'd ask you this question first. Apart from capsule staining, what's something else that I could have done to improve my visualization intraoperatively?
Sorry, let me unmute myself. First of all, I want to thank you all for having asked me to join this fantastic panel. Jackie, already your talk is amazing, and I'm honored that I'm the first person you're asking a question of. As far as a patient like this, where corneal edema is the main reason for the decreased visualization, often removing the epithelium can give you enough improved visualization that you can proceed with surgery without much further intervention. Sometimes also using a pen light right at the limbus and doing kind of a trans illumination also has helped with depth perception in these cases. But removal of epithelium 90% of the time in these cases seems to be enough.
Thanks, Dr. Shami. And that's exactly the thing that made the biggest difference. I tried everything except the pen light, actually. Thanks for that tip. But removing the epithelium really made the biggest difference. It was quite hyperplastic, and it really shows me that I need to think about replacing that endothelial keratoplasty. if the patient's keen on that, and really can make a significant difference, as well as some of the other things on those lists there. The next thing that I'll go onto is endothelial protection. This is really important in patients with corneal disease, and it's about trying to prevent post-operative appearances like those shown here with corneal decompensation. Consideration needs to be paid to anything that we put into the anterior chamber, as well as how we choose to remove the cataract. So in terms of what we put into the anterior chamber, there's the irrigating solution, and several features of that might impact the endothelial cell loss. Time, volume, chemical composition might be considered. There's been shown to be no difference in cell loss at 6 months when balanced salt solution has been compared with Ringer's lactate irrigating solution, although it does make theoretical sense, and it's certainly what I use for cataract surgery. Other solutions such as balanced salt solution plus approximate characteristics of aqueous humour a little closer, and therefore might provide theoretical further advantage. However, once again, that's not actually been shown to be a significant difference compared to the simpler Ringer's lactate solution. Intracameral medications such as anaesthetic agents, mydriatic agents, and antibiotic agents are frequently used during cataract surgery. It's really important to ensure that the correct concentration of any drug is used to avoid corneal toxicity. Preservative-free lignocaine has been shown to result in no change in endothelial cell count at 3 months, but high concentrations can cause significant endothelial cell loss. So it's very important to be careful. Also, as some of these medications are off-label and availability and approval varies between countries, it's really important to make sure you know what is and isn't appropriate to use in your area, and to follow those guidelines appropriately. Apart from maintaining a workspace, the whole point of viscoelastic is to protect the corneal endothelium. I prefer to use a soft shell technique described by Arshinov and found to be protective during phaco of at least dense cataracts. In this technique, a dispersive OVD is placed first, followed by a cohesive underneath, as you can see in that video. Advanced phaco technologies give increased efficiency, reduced repulsion, reduced turbulence, increased followability, and reduced risk of wound burn. These technologies likely do reduce the energy used. It makes sense, but has not really been shown that they reduce endothelial cell loss. Likewise, a number of different handpieces and tips have also become available that again make sense in terms of protecting the endothelium, but have not as yet at least been shown to greatly alter cell loss. And I think there's room for a lot more research in this area. Oliver Findle and his group have done some work developing a swirling fragment score to improve cataract surgery. Basically, what they did is use intraoperative continuous anterior segment OCT to show that swirling fragments hitting the corneal endothelium cause cell loss, especially small fragments that probably hit the cornea faster. One possible effect of that research is the justification that something that is fairly intuitive for us, that we should phaco away from the cornea as close to the iris plane as possible, especially in these higher risk cases. So here's the next question, and Dr. Jacob, I'll direct this one to you if it's okay. In terms of nuclear disassembly, how would you disassemble the nucleus for best endothelial protection?
Yeah, thanks for that question, Jackie. And again, thanks Ashwin and Jen and Bill for inviting me here to this show. It's really an honor to be here with such a great panel. As regards the question, I think for me, like you said, working in the bag is the most important thing. You try to work away from the endothelium as much as possible. Considering that this is just a pure phaco and you're not also combining it with an endothelial keratoplasty. Of course, if you're combining it with an endothelial keratoplasty, it becomes exactly the reverse, which means there your priority is to save the posterior capsule at all costs because you want that air management to be good. So work away from the endothelium, and you could do a divide and conquer. You could do a phaco chop. Do whatever is comfortable for you. Use torsional ultrasound. That's important, and it does help to decrease the damage to the endothelium. And the soft shell technique, of course, helps a lot. You should keep replenishing it. And at the same time, you should also make sure that you don't get wound burns because of the use of the dispersive, viscoelastic. And another thing that I also do is when the cataract density is really hard, sometimes I just prefer to do a small incision cataract surgery. And I think that makes a lot of difference instead of, taking a chance and having to use a lot of ultrasound energy within the anterior chamber. It's really simple to just get the nucleus out as a whole, very atraumatically, just through a small incision cataract surgery. And I've done many of these cases, and I see that almost all of them do very well, even with low endothelial cell counts.
Thanks, Dr. Jacob. That's some really good points. And I really agree, especially with that do what's comfortable point that you noticed. And so phaco chop is one option for disassembling the nucleus. And this has been shown to give some advantage, at least for the moderately dense cataracts. And I think that phaco chop, of whichever way, are important techniques that we should all strive to be good at. But just like Dr. Jacob, I caution that the benefit's reasonably small and only for moderately dense cataracts. So don't try it for the first time in a high-risk case. If it's part of your skill set and you're good at it, then these might be the good cases to chop.
Actually, I think you're going on to the femto. That's exactly what I wanted to comment on.
Yeah, sure. But make your comment first, if that'd be interesting.
I mean, I think I absolutely agree with you. I think phaco chop is a fantastic skill to have, especially for these cases, but just in general, the more tricks we have up our sleeve as surgeons, the better we are in being able to manage situations that may come our way. And I find that to be the case with cataracts, corneal transplants, any type of surgery I do. It's also the case in being a parent, by the way, having multiple skills up our sleeve on how to manage our children. But I also really like femtosecond laser-enabled cataract surgery in these cases, because even though many of the studies have not necessarily corroborated or validated this point, by modifying the fragmentation patterns of my cataract, I personally find that my phaco times are lessened. I like to do the waffle pattern, for example, or I do the sextants if I'm doing the Alcon LensX. And I tend to use less phaco energy. But the caveat to that is with femtosecond laser enabled, when we do the hydrodissection, we tend to burp the viscoelastic prior to the hydrodissection so that we don't overpressurize the eye. So I then reintroduce viscoelastic after the successful hydrodissection, whether or not the patient has a fragile endothelial layer. But that's a real important extra step that you need to take for those cases.
Thanks a lot, Dr. Shami. I really agree with a lot of those points, and I'll give a little information about that. So as you pointed out, laser cataract surgery probably can reduce the cumulative phaco energy that's needed to disassemble the lens. Whether that causes significantly less endothelial cell loss in the long term compared to conventional cataract surgery is unclear. A study by Rob Abel and Brendan Vogt from Australia showed that corneal edema was significantly less with laser cataract surgery compared to conventional at 1 day and 3 weeks post-op. However, that difference was negligible at 6 months. And in the same study, they found that the endothelial cell loss was less at 3 weeks, but not at 6 months. So you're right, it hasn't really been shown, but it intuitively does make sense that it could be an advantage. Interestingly, in that study, the eyes that had laser incisions had greater endothelial cell loss at 6 months than eyes with manual corneal incisions. And a bigger study, a meta-analysis of 9 randomized controlled trials and 15 cohort studies, suggested that laser is safer and more effective for reducing endothelial cell loss than conventional phaco. But I do note that that conclusion was based mainly on evidence at 3 months, and that very few of the studies extended beyond that to 6. But ultimately, I think you're right there that we don't really know if laser is an advantage. It makes sense that it might be. The thing is, just once again, the same point is that I don't think these more complex cases are the time to change your technique. It's great to have different techniques up our sleeve if possible. But perhaps if you usually do laser cataract surgery and you're good at that, it might be a good choice for these cases like you do, Dr. Shami, but otherwise I would stick with your normal technique. Next, I'm really glad that Dr. Jacob brought up extracapsular cataract extraction. I don't, unfortunately, know how to do manual small incision. But there are definitely cases where an extracapsular extraction does give advantage. We've all seen those patients that require very rapid visual rehabilitation. We don't want them to suffer endothelial decompensation and a long road to recovery requiring transplant. And they may be much more likely to achieve that after extracap. And particularly the manual small incision technique has been shown to have very good results. Again, it's been difficult to show a difference in endothelial cell loss. A meta-analysis of randomized controlled trials found no significant difference in that between phaco and manual small incision, but it does make, again, intuitive sense. And we have all seen those cases with the clear cornea day one post extracap that they're just not going to have after phaco of a dense cataract.
If I can comment,
yeah,
I may be, again, ahead of your next slides. I'm sorry, I haven't seen your talk yet, but my loop in those advanced cataract patients, if you don't have access to the femto, or even in cases with femto, with those very dense, waxy nuclear cataracts, my loop seems to really work nicely on them and has minimized my phaco time.
Well, that's a good one. Thanks, Dr. Shami. I haven't included it. And actually, I haven't used my loop yet, but I have some opportunity to next year, and I'm looking forward to that. It's a good point.
The first time you use it, you may have to tap into your daughter's interest in was it trapeze that she wants to be? Yeah, it feels like you're going to be doing a trapeze act. The first time is quite scary, so I would not recommend trying it in a complex case first. But yes, after the first try, it's amazing how well it works.
I think thank you, Nina. Susan, you want to say something?
Yeah, I just wanted to make a point here also that when you're removing these dense cataracts, if you've got a well-dilated pupil, it would actually be better to do a manual small incision cataract surgery than the standard extra cap, because the antechamber remains better formed, and you can have that endothelial protection retained much better than, having to kind of press the cornea and get it to slide out with much more chances of the nucleus actually rubbing on the cornea. With an MSICS, the antechamber remains well formed throughout, and so the protection is much better.
Oh, thank you. And it's also on my list of things to learn for 2021, because I was a little shy to show my extra cap technique in front of you, because I know there's a much better technique than that. So just to sum up the endothelial protection, the things to think about are the intracameral agents and viscoelastic that you're putting in the anterior chamber. Avoiding a post-operative intraocular pressure rise is also important, and then the phaco technique itself. Now, the next thing to consider with patients undergoing cataract surgery with corneal disease is wound integrity. And this is particularly important for patients with Fuchs endothelial dystrophy, corneal ectasia, or post-keratoplasty. Patients with Fuchs dystrophy have increased risk of Descemet's membrane detachment. And it really, and it's very important to consider this the whole way through surgery, every time an instrument goes into the eye and with wound construction itself. And post-operatively, if there's corneal edema, particularly if it's segmental as shown in this photograph, it's important to look for a Descemet's membrane detachment. And you can do that on the slit lamp, looking for the double anterior chamber, or as shown here with anterior segment OCT. It really needs to be identified because often it needs surgical correction.
Jackie, if I can just make a point here also, it's a beautiful point that you said that Descemet's detachments can be more common in these patients. And one tip that I'd like to give to everyone who's listening here is that when you're, especially, you would have done a beautiful surgery, or you've not got any Descemet's detachments, you kind of feel confident that you're going to have a clear cornea the next day. But then you do your stromal hydration. for the ports. And if you're too posteriorly placed towards the descemetes, there is a chance that that fluid wave is just going to detach that descemetes and call what I call as a bolus descemetes detachment. So those kinds of descemetes detachment don't, even if you recognize it, you kind of see it as a wave passing across when you're doing the the hydration of the ports. If you have recognized it, it's good. All you have to do is enlarge that port so that you have a break in the descemetes membrane now. Otherwise, what happens is there's no break, and if you just put in an air bubble, the fluid still remains there because the fluid can't escape. It's basically trapped fluid. So make a small, just make a keratome entry so that you've cut the descemetes membrane through and through, and then put in an air bubble from the opposite side, and you'll be good to go. So just keep an eye on that and do your stromal hydration a little more anterior than posterior.
Really good advice. Thank you.
Can I also comment? I think that was a fantastic point. I actually avoid doing stromal hydration in patients with Fuchs dystrophy because of this reason. And I'm more inclined to, one, place my corneal wound more posterior, so that, there's a little bit of bleeding from those vessels from the conj, and hopefully, and then, tunnel my incision a little bit more so that I lessen the risk of leakage, such that I don't have to do hydration of the stroma around the wound. And I'm more inclined to place a suture than hydrate, because I've had this happen, and it's so frustrating after a fantastic surgery, and this happens. And sometimes even with an air bubble, you may not be able to recuperate the eye, the cornea.
Great point.
Yeah, they really are great points, and especially suturing. They may not be the cases to just keep on trying with hydration. It can be a lot safer just to place a suture. In patients with keratoconus or post-keratoplasty, the actual position of the wounds is important, especially patients with corneal ectasia. They're at increased risk of wound leak, and it's important to close all wounds, but also pay attention to the position of the wounds, bearing in mind that you may need to suture them later, and that can be important with keratoplasty. Now, of course, despite extra care and attention, complications will still happen. Initial management of complications is no different for patients with corneal disease, although it may be more difficult to see what you're doing. As you always would, stop, consider, stay in the eye, breathe, and place viscoelastic prior to taking the infusion out. Cataract surgery complicated with vitreous loss is associated with increased endothelial cell loss and an increased rate of corneal edema. Retained nuclear fragments, should that occur in the anterior chamber, can also lead to corneal decompensation. And lastly, if capsular support is completely lost, the IOL placement must be really well considered. And that brings me on to the next panel question. Dr. Price, I think you've got the hardest question so far, which is, what would be your choice of intraocular lens in a patient with corneal disease who now has absence of capsular support?
Well, thanks for giving me the easy one of the night. And I want to thank you all for inviting me to be here. This is a really interesting format, and I think it's a lot of fun. So let's just start at the top here. We really don't have access to iris claw in the United States. And you could do that, but I'm not sure if you're going to combine this with a endothelial keratoplasty. That'd be a wise thing to do. You might dislocate it, especially if you have a posterior inclination. I don't use any anterior chamber lenses. I don't think there's actually a good anterior chamber lens. I think they all potentially have some problems with what they do to the angle in the cornea. Iris suture lenses can work. I've done those in the past, but they're a little bit hard and difficult. We stopped suture fixating posterior chamber lenses a number of years ago because the proline sutures all degrade. If you're going to do a scleral fixated, then you should really use a 5, 6, or 7.0 polypropylene because the ciliary body will degrade the proline or the polypropylene, whereas the iris doesn't. Ashvin showed us how to do the glued posterior chamber lenses, and we did that for a number of years. But we've now switched to the Yamane, and that's what we do. And actually, I had my first posterior capsule rupture with a DMEC in probably I don't know, 5 years last week. And so we did a Yamane and were able to safely do a large air bubble and finish the DMEC case. So we like the Yamane because it's a small incision with the needle. It's less likely to lead to hypotony postoperatively. And it's just been real reproducible. You want to have a posterior chamber lens like one from Zeiss that the haptics don't break very easily. You can leave patients aphakic, but they're not going to be very happy unless they're a really high myope. So we try not to do that. And if you're doing a combined endothelial keratoplasty, leaving them aphakic means that your bubble probably won't stay in the anterior chamber as long as you want. And it makes it very difficult to safely do a DMEC. So I think it's better to do E, the Yamane. That would be our choice. And we have all of our fellows learn how to do pars plana vitrectomies so that you can do that safely without any vitreous entanglement.
Thanks, Dr. Price. I'm sorry that happened to you last week, but it just shows, doesn't it, that we really need to be prepared for any outcome when we go into surgery. And certainly a Yamane would not be what you're planning when you're going for a combined DMEC cataract surgery case. But there is a little bit of specific equipment that you need, and you obviously have it on standby and everything ready to go. So thanks for going through those options there. I wonder if anyone else has anything to add or a different preference than what Dr. Price suggested.
Oh, sorry. Go ahead, Susan.
Okay. So, you know, being from the land of gluteals, I still do gluteals with all my PDEX and endothelial keratoplasties. And the things that I think make a difference or what I do slightly differently in these cases than the routine gluteals is that I take the sclerotomy ports a little more anterior because that gives me better contact, so to speak, with the iris. So there's less of a gap, and possibly the same would also be applicable for Yamane. I'm not sure if it could be done. If it could be done, because I haven't done too many Yamanes. But if you bring the ports a little more anterior, the chance of that air bubble actually passing between the iris and going into the vitreous, and thereby you're losing your postoperative air support is much lesser. So I think that's one big difference. The second thing I do is after the gluteal, I do the gluteal first, and then I close the scleral flaps. And once I've closed this with fibrin glue, once I've closed, I've tucked in the haptics, of course, and once I've closed, so seal those haptics, those flaps with fibrin glue, I find there's no air escape at all. And that gives me, you know, much better control during the PDEC or part of it, which I do afterwards. So those are some of the, you know, changes, of course, with the pupilloplasty when required, that I do when I combine the two surgeries.
Before we give it to Neda for 1 second, I just want to add one point to this. I mean, viewers around the world, it's very important both the points are very, very valid, but it's very important to know that the intraocular lens that you use in the Yamane is very important. I mean, that lens has to be the PVDF haptic because that's what really makes that procedure work very, very well. And unfortunately, they've not been able to expand that manufacturing to actually serve the rest of the population. And one of the factors that a lot of countries in the world don't actually have access to that particular lens. And, you know, I've seen people try out different IOLs and it doesn't work in different hands. Maybe it works in few hands, but many hands it doesn't work because it's brittle or it kinks or breaks, or I don't know what happens to it, but it doesn't work. So that point being said, you probably need to have both these procedures in some way or the other in your armamentarium. You know, it's like to learn phaco, you have to know ECC and suturing, and it's as simple as that. So you want to do Yamane, you want to know gluteal as well. So it's your escape route.
Yeah, I totally agree with Ashvin on that. The problem with most of the IOLs is that the haptics do break easier, and the glued IOL technique is much more forgiving.
Neda, all yours.
I wanted to comment. I think all of the points you all brought up are very important points. But in the case that you were presenting, Jackie, it looked like the anterior capsule was, at least the rim was mostly intact. And I would say that if it's just a rent in the posterior capsule and the zonules are fine and the anterior capsule is stable, then a sulcus IOL, and my preference is the LI61AO because it comes out very planar, is a really fantastic and atraumatic option, obviously after having done a nice vitrectomy to make sure that no vitreous prolapse comes through. And then doing a sulcus IOL of a 3-piece and capturing the optic in that centered anterior capsular opening is a perfectly fine option for these cases, at least in my hands, I think.
That's really true, Dr. Shami, yeah, and that is what we did for that case because the capsule was intact. But I was really interested in that discussion about what if the capsule isn't intact and what would we do? Yeah.
I definitely take a sigh of relief when the anterior capsule is intact and the zonules are fine. The other point I wanted to make is that keep in mind the type of IOL used in scleral fixated is important. If there is any corneal disease and you anticipate needing to do air management post-op, such as DMEX or D6, because some of the scleral fixated lenses can opacify with exposure to air.
That's right, particularly the hydrophilics, right? So
exactly.
Yeah, also a good point. So in terms of the surgery, the 5 key things to think about are forward planning, optimizing visualization, protecting the endothelium, thinking about the integrity of the wounds, and complication management. We're having some good discussion, and I think that these cases might let us have a bit more. Sorry, go ahead.
Jackie, just one more thing, you had made a beautiful point about how the wound construction is important when you're combining it with keratoplasty. And I think that's really crucial, especially for those who are starting out, because, when you see the cornea, the keratoplasty from above, and you think you're posterior enough, but then you make your tunnel and you find that you're hitting the inner edge of the graft. So that's really crucial because you need to kind of calculate with the inner edge of the graft and the length of your tunnel, and then, decide how far posterior you're going to be. Sometimes you may need to make a scleral tunnel, you might not even be able to go corneal. So those are really important considerations when you decide where to place your incisions and how to make them.
And that's true. Thank you.
We do have a question from the audience before we move to cases. I just wanted to put it out there. It's a suggestion / question. I'm not sure. Do you recommend using a capsulorhexis button in laser cataract surgery for extra protection of the endothelium during phaco surgery? I'm not sure how that works, but do you guys have any comments on that? I'm not sure if this works because that button will just keep moving around, right? I mean, with the fluid wave.
I haven't thought about that before either, and I guess they mean as a physical protection. But I think you're right. It would be moving around, and you also don't want that even too close to the corneal endothelium. But I haven't tried that.
Right. Frank, Susan, anybody?
Yeah, I haven't tried that either. I think a dispersive OVD would be good. And if you actually put in the capsule there and then put in dispersive OVD below that, you might actually have some difficulty in removing that capsular, that bit of the remnant of the capsule from there at the end. And then you might actually cause more trauma in trying to remove it. So be careful about that because dispersive doesn't come off as easily as, cohesive.
I actually had a patient with corneal decompensation referred to me because of exactly that the surgeon, when they did the femtocataract, they didn't notice that the capsule was floating already and put viscoelastic under the capsular cap, and the capsular cap was sticking to the endothelium, and at the end of the case was still there, and then the cornea decompensated. So I would say it's, at least in this one case that I saw, it caused corneal decompensation in an otherwise normal cornea.
And I had one too, Dr. Shami, where the surgeon had gone to remove what they thought was the floating anterior capsule at the end of a case, and it was actually a flapping edge of Descemet's membrane. So
oh, wow.
We do have to be careful of what we're grabbing.
It's interesting, yeah.
Sorry, go ahead.
So some cases. This is a patient of mine who was a 64-year-old lady referred to me from another ophthalmologist with cataract and corneal ectasia. But the patient had been referred to him by an optometrist with reduced visual acuity. Importantly, the patient had no symptoms herself, but she'd had a finding of cataract by the optometrist, and then at the time of workup for cataract surgery by the ophthalmologist, had this corneal tomography, which shows corneal ectasia, a little atypical as far as keratoconus goes, but still steep K values with a maximum K reading of 51 and thin cornea with the thinnest point lining up with that steepest point of the cornea. And this patient did have a history of trauma. However, the other eye, the left eye, did have a very similar tomographic appearance to this. However, a little bit less steep but more irregular, and a best spectacle corrected visual acuity on that left eye. The right eye had a best corrected visual acuity at presentation of 20/80, and they did have moderate cataract. But I didn't do anything because the patient didn't have any symptoms. So my first decision was to explain the corneal problem to the patient and then follow her up over time. And she came back 6 months later with no progression of symptoms. And importantly, the difference maps of corneal tomography that are shown here did not show any change in her corneal status. So still I didn't do anything, but the patient came back at 12 months with much worse vision. So she now has dense cataract, posterior subcapsular, and visual acuity of best corrected 2400. So I guess I'd better do something now, right, Dr. Shami? Could you please help me think about how I should measure keratometry values for this cornea and what sort of refractive target I should think about aiming for?
Didn't you say Dr. Price is going to get the most difficult questions? Wasn't that the promise you and I made together before all of this? I want to toss it to, no, I'm just kidding. So a couple of points. I think this is a really excellent case. And interestingly, I had a similar case today, very much like this, just right before getting onto this webinar. A couple of points I want to highlight. So the fact that the patient herself wasn't symptomatic a year or some ago when they had early signs of cataracts points at her having managed throughout her life with this irregular, or through the recent years with this irregular astigmatism and irregular cornea, and that she is not someone who's reliant on RGPs or scleral lenses, for example, for most optimized vision. So that's one decision point that's really important. Another one is that her corneal topography pointed at an irregular astigmatism, but one that didn't give us much of a bow tie centrally. So a toric option is going to be off the table in that case. Now, there are, as you know, keratoconic patients that even though there is significant asymmetry in the central 3 millimeters, there is a bow tie. And those patients may not have been symptomatic because they had their astigmatism corrected with manifest and with spectacles, and they could be toric patients. But this patient did not look like they had a bow tie appearance. The other point I want to make is that the thinnest part of her cornea, it's definitely an atypical presentation of keratoconus, but given the symmetry between the two eyes, she just may be an atypical type of KC or ectasia. But the thinnest part was temporal in the right eye. I would avoid a temporal incision in this patient at all costs, and probably do a superior scleral incision in her, or superior clear corneal, to avoid destabilizing her cornea further. I would still, unfortunately, I would still go ahead with my measurements. I would like to do an intraoperative aberrometry in her, and I would target a more myopic refractive outcome, knowing that the estimation centrally will be off, and all of those. And I would most definitely do a standard lens for her, and not anything advanced, and educate her about the fact that she'll likely need glasses and most likely maybe a scleral lens for the most optimized vision.
Thanks very much. They're really good points, especially actually that avoiding the temporal incision. And I'm thinking back to doing the case. I hope that I did that. That's quite important. So this is my calculation. I use the Barrett Universal Formula. I do a toric calculation for everybody, but like Dr. Shami said, I did not intend to put a toric lens in this patient because of that not being suitable. I did keratometry values every way that I have. I don't have intraoperative aberrometry, but as you can see, they didn't really match at all. So ultimately what I put into the formula were my IOL master K values. I chose, with this patient having kind of mild to moderate keratoconus, I chose a refractive target of minus 0.5, and my non-toric IOL that I planned happened to be 17.5 diopters. And post-operatively, she did pretty well. She had uncorrected visual acuity of 20/32, and her, I think this is random, but she actually didn't need to change her glasses, and she got 20/25 with those same glasses. But you can see that my target was a minus 0.5 diopters, but her final spherical equivalent was plus 0.5. So she was thrilled, but I thought I should have aimed more myopic.
Jackie, I agree. Netta was right on. Sorry.
No, go ahead, Bill. Dr. Cutler, is that you?
You're on mute. You're on mute, Bill. No.
Bill, you're muted out.
You able to hear me? Sorry about that.
Whilst he sorts that out, let me go ahead and ask the panel, because I haven't targeted someone specific here, but in general, do you think I used the right formula?
Well, you got a good result, so I would say that you did.
Yeah.
What other formulae could I have used?
Well, you know, the keratoconus eyes are really unpredictable.
Yeah.
Because you don't know how it's, you know, you don't really know what the real Ks are where the patient's looking through. And so it's a bit of a guess. And so typically I won't put in a toric and a keratoconus eye unless it's extremely mild, because I wait and see where they're going to end up post-operatively. And I personally try to aim for a -2 if they have significant keratoconus, so that they can see to put in a contact lens if I can't refract them real well post-op.
Okay.
We have 5 minutes left, so yeah, let's keep moving. But yeah, Susan, you have a...
Yeah, just one thing I'd like to also say in this case, Jackie, very interesting case was that, you know, it would be nice if we had I don't know whether you mentioned it, I missed hearing it, whether we had a contact lens, rigid gas permeable contact lens trial prior to surgery, just to find out, you know, whether the patient's cornea is completely responsible when she was still at 624, or was there a component of cataract also at that point of time? And if the cornea was also at least partly responsible for decreased vision, one thing that I might consider doing is also implanting an ICRS, because that's typically, pushed away cone, an eccentric cone. So we could, there's something that I do, which is corneal allogenic intrastromal ring segment scares, which you can just have allogenic tissue there around that, and that would kind of flatten out that area. And you would have a much more symmetrical cornea, and that might possibly make I haven't really done this in a similar case. I'm just hypothesizing that could possibly be an answer to getting a more reliable biometry finally.
Yeah, I can see that actually. She could have been a good case for a single intracorneal ring. Thank you. I did not do the hard contact lens trial preoperatively. I think there was some component of cataract. Well, in fact, now I know, because she got a better result with cataract surgery. But she had moderate nucleus sclerotic cataract at that time of first presentation. So I presumed it was impacting her to some degree.
Yeah,
but
I think a preoperative RGP trial makes a lot of sense in these cases, because then you can distinguish the component that's because of cataract, especially nucleus sclerosis. You can often refract 266 despite the nucleus sclerosis, or 20/20. So you kind of get an idea about, is it the cornea or is it the lens?
Yes, thanks. I might move on just so we can cover just quickly a couple of other options that I could have used. So there's several newer formulas now that make adjustments for patients with keratoconus. And this is Graham Barrett's True K formula. And this was for patients with prior myopic or hyperopic LASIK, but there are also options to select previous radial keratotomy or keratoconus. And in this example here, this is where Dr. Barrett has used a theoretical adjustment for the posterior corneal power that might be more appropriate for a keratoconus patient. Interestingly, in my case, that formula would have given quite a good result. Also with that same formula on the same page of the calculation, you can put in the actual measured posterior cornea values, which I did. This is retrospectively after I'd already done the case. But I took the values from the posterior curvature map of my corneal tomography and entered that into the formula. And you can see it did not make a difference to my selected intraocular lens. But I did also want to mention this formula. This is a formula by Jack Kane, and he's actually a trainee here in Melbourne, Victoria. We're so proud of him. He is a true rising star in ophthalmology. He actually only passed his exams for ophthalmology last week, but he's already created this several formulae. But this is his one with keratoconus modification. It's available online. And he has also developed a theoretical modification for patients with keratoconus that take into account their different posterior to anterior corneal relationships to try to give a more accurate expectation for these patients. And he's recently published in Ophthalmology where he found his formula had a better prediction than the Barrett Universal 2 or the SRKT, which is often being used for keratoconus. But it would be interesting in the future to see a comparison between this formula, Jack Kane's with the keratoconus modification, and Graham Barrett's True K with the keratoconus modification, because that one wasn't included in this paper. We might skip, but we've already covered a few of these questions. So are there any just final comments about that case?
Yeah, I think small aperture is again a good idea for the especially highly aberrated corneas. You have different kinds of IOLs that are available as small apertures, and you also have the pinhole pupilloplasty, which can also be done for these cases, where you can actually also kind of fix the pupil exactly where you want it to be, rather than in IOLs where it's a fixed position. So those are, I think, some other very good options for highly irregular keratoconus patients.
Plus the accessibility around the world, right? I mean, that becomes an issue when you're doing something globally.
And that's true. And the pupilloplasty is a really good technique for that. And you introduced me to that concept, Ashwin, and it really can be useful.
And I know Dr. Price, mentioned that one should hesitate implanting toric lenses in severe keratoconics. And that's typically my approach, although I have implanted T9s, even up to T9, really high correction in someone who not only has a central, the central 3 millimeters of their corneal topography is mostly regular, as well as a person, or in addition to giving the history of having had good enough vision with glasses or soft contact lenses. So if a patient tells you that I'm not reliant on RGPs or sclerals, they have astigmatism as a result of their keratoconus, and their corneal topography gives you that central bow tie, then even up to T9, I've had great success with those patients. But they're rare. Those types of patients are very rare.
Yes, thank you. And
I think for one last comment from somebody, and we really need to close.
I agree. Just for the audience sake, of course, when you do these cataract surgeries in keratoconus patients, they're generally at a more advanced age. But if you, for any reason, are doing it at a younger age, you have to make sure about the stability, which you did, Jackie, in your case. But stability is important. And if it is unstable by any chance, please do a cross-linking first and get the cornea to be stable, and only then proceed with the cataract surgery.
Yeah, really important. Thank you. Now we are getting the wrap. So I would just like to say thank you so much for having me to give this presentation. Thanks for all of that discussion, everybody. These are some images of our trainees in Australia at our OSCRIS conference and just training. And we'd love to have any of you down under at some time in the future. And I really can't wait to be back over there doing conference with all you guys. Thanks so much for including me.
Thank you.
Thank you so much. Great talk. Great talk.
Very good.
Closing in today, we would like to thank all my celebrity panelists and Jackie especially you, for an amazing talk, and the discussion around it was extremely valuable to a lot of the audience around the world. Wish to inform you all that this episode will also be available online on our risingeyestars.com 48 hours from now. And our next episode is on Jan 13th. So wait and watch out for that. To know more, just go into the website and you'll know more. Thank you, everybody. Thank you so much for doing this, for being here, and happy holidays for Christmas and New Year. So enjoy yourselves, guys.
Thank you.
Take care,
Thanks.
everyone. Great
Very
talk.
nice.
Thank you so much.
Thank you.
Really fantastic. Thank
Nice.
you.
Nice
Bye,
job,
everyone.
Jack.
Thank
Very
you.
nice job.
Jackie.
Fantastic.
I don't want to leave.